Good afternoon, everyone, and welcome to the CAPER Pancreas Academy. This is our third session of 2025. Today, we are thrilled to welcome two excellent panelists with us who are going to give some talks to us actually on chronic pancreatitis. Both on the disease process as an overview and then also on endoscopic management. And so we look forward to these talks. And today, first, we'll be very honored to welcome Dr. Julia McNabb-Baltar, who we are thrilled to have here with us at the University of Pittsburgh. And briefly, Dr. McNabb-Baltar is a medical pancreatologist who specializes in GI as well as medical pancreatology. And she is a practicing gastroenterologist and pancreatologist here at UPMC. We are thrilled to have her. She's an expert in chronic pancreatitis, and so we look forward to her talk. And without further ado, Julia, I'm just going to mute and close my window here and have you take it away. Thank you so much.
Thank you. Thank you for this kind of invitation. I'm so happy to be chatting with you all about this important topic. Really, I appreciate this wonderful invitation. As Dr. Phillips said, today I'm going to talk about chronic pancreatitis, etiology, and medical management. This is my conflict of interest, previous research report from Nestle Health. So this is what we're going to talk about in the next 20 minutes. We're going to focus on reviewing the etiology of chronic pancreatitis, and we're going to do that using the Tiger framework. Then we'll discuss the medical management of chronic pancreatitis, go over evidence-based pharmacological treatments, nutritional support, pain management strategies, and then we'll talk about the role of pancreatic enzyme replacement therapy. So if we go over the Tiger classification, you can see that this is an acronym that stands for, T stands for toxic metabolic, and that includes multiple things, including alcohol, tobacco smoking, hypercalcemia, hyperlipidemia, chronic renal failure, medication toxins, and then through those, there's different effects at the level of oxidative stress, toxic metabolic, and also necrosis and fibrosis that can lead to chronic pancreatitis. At the level of idiopathic, you can have an early onset, late onset, tropical pancreatitis, and we'll go over all of those in a little bit more detail. Genetic, we'll talk about different genes that have been associated with risks of developing chronic pancreatitis that can lead to necrosis, fibrosis, the SAVE hypothesis, as well as duct and stone obstruction. And then autoimmune, we'll talk about the different type of autoimmune chronic pancreatitis, as well as look at recurrent and severe acute pancreatitis. And finally, we'll look at the different steps. So toxic metabolic factor first. So alcohol, as you see, has different ways of contributing to injuries to the pancreas. So heavy and long-term alcohol consumption will have an effect at the level of the nerve with decreased cholinesterase. Also at the level of the stellate cell with stimulation of transformation to fibroblast. At the level of the acinar cells with decreased secretion through this decreased circulating CCK, as well as induced basolateral secretion. Can also disturb the segregation of enzyme, lysosome, and exocytes, and disturb the energy metabolism, as well as the protective measures in the endoplasmic reticulum. And as well as the duct level, it can inhibit NaHCO3 and water secretion and produce protein precipitation. So you see that alcohol has effect at many different levels in the pancreas. So we usually say that you need to consume 4 to 5 standard drinks per day to have a really increased risk of developing chronic pancreatitis, but that regular consumption at a lower level is also likely a cofactor. And we know that approximately 5% of chronic alcohol users will develop chronic pancreatitis in their lifetime. We know that there seems to be a dose-dependent effect, and that really there is not a safe limit of alcohol consumption that has been established. So alcohol abstinence is very important and something that we need to encourage in our patient population. Now, if you look at smoking, smoking also has an effect at multiple levels in the pancreas. At the level of the brain, it will stimulate the acinar cells, the ductal cells, that can lead to increased necrosis to the SAPE hypothesis. It also has an effect at the level of the acinar cells through pro-inflammatory immune response that can also lead to fibrosis. So we know that over 50% of patients with CP are current smokers. There seems to be a dose-dependent effect. So if we look at meta-analysis, if somebody smoked less than 1 pack per day, their relative risk was 2.4. 1 pack or more, the relative risk was 3.3. A current smoker 2.5, and then former smoker 1.4. So really, a dose seems to be a dose-dependent effect. And we know that combined exposure with alcohol also significantly raises the risk of developing CP. Hypercalcemia is also something we mentioned. We don't see this as often, obviously, and it's often due to primary hyperparathyroidism. And this is through two main mechanisms, the increase in the trypsinogen activation from the increased calcium concentration. And you can also have calcium deposition from, again, the increased calcium concentration that can lead to inflammation and chronic changes. Hypertriglyceridemia, usually we want triglycerides to be over 1,000 milligrams per deciliter. And this is really because there's a release of toxic free fatty acids. So the triglyceride itself is not toxic, but the free fatty acid are. And usually will cause chronic pancreatitis, not directly, but through recurrent acute pancreatitis. If we look at other toxic metabolic causes, chronic renal failure, we don't really understand that relationship so clearly, but it looks like it's probably something multifactorial, including uremic toxins, also alteration in the electrolytes like hypercalcemia, could be also toxicity of the dialysis solution, infections, and then potential damage from the dialysis process. Medication also can cause toxic metabolic injury to the pancreas, and it's usually through recurrent acute pancreatitis injury. And finally, toxin, we often think of organotin compounds such as DBTC that can be seen as a substrate in different products, and that can cause chronic pancreatitis through biliary obstruction as well as direct toxic effect through mitochondrial dysfunction. Now, if we segue in our eye and our Tiger Road classification, the idiopathic chronic pancreatitis, there's really kind of three subsets, but as you'll see, we're kind of moving a bit away from those. So early onset is defined as less than 35 years old, a diagnosis. And the median age is usually 20 years old. Pain is really a predominant presenting factor, and advanced pancreatic damage is seen, as well as EPI or exocrine deficiency those are rarely seen, or they can take decades to develop. And we've seen that about 50% of them actually have a genetic variation. So we may be moving away from idiopathic and putting them into the genetic classification. For late onset, that happens after 35 years old, the median age is 56, and we see pain in about half of those patients, and it's frequently associated with calcification, exocrine or endocrine dysfunction. And then there's a tropical or fibrocalcific that usually presents in childhood in more developing countries. Southern India is a stronghold for this type of presentation, and the patients present very young in childhood with fibrocalcific disease, malnutrition, diabetes, and they experience early death. And there may be a component, again, with a complex genetic predisposing to this subset as well. Now, if we segue into genetic factors, as you can see, there's genes that can affect cause acinar risk as well as ductal risk. So at the level of the acinar, you can have early trypsinogen activation as well as impaired trypsin inhibition and endotroplasmic stress. And at the level of the ducts, you can have altered fluid composition and as well as disruption of the calcium homeostasis. And there's different pattern of genetic transmission, autosomal dominant with the PRSS1, autosomal recessive, for example, SPINK1, X-linked like Claudin-2, and as well as protective mechanism with some PRSS2. So when we talk about hereditary pancreatitis, we usually think of a mutation in PRSS1 gene that's identified in between 65 and 80% of cases. And it's an autosomal dominant with incomplete penetrance mode of transformation. And so we can see that 20% of the patient with PRSS1 gene mutation won't develop pancreatitis. So it's through a gain of function where the trypsinogen is auto-activated, becomes a super trypsin that is hard to inactivate, that will lead to acute, recurrent acute, as well as chronic pancreatitis, and also increases the risk of developing pancreatic cancer. The lifetime risk is about 40%. And so PRSS1 variants can also be identified in idiopathic chronic pancreatitis and in idiopathic recurrent acute pancreatitis as well. Other genes we can mention is SPINK1, where you have a pancreatic secretory and a trypsin inhibitor. So this is a gene, a modifier gene, where you will lose the inhibition of trypsin. And we can see this often in healthy individuals. So 2% of healthy individuals carry a high risk variant of this SPINK1. CFTR with or without cystic fibrosis, CTRC, those are more at the level of the ductal carbonate secretion defects, and those are strongly associated with recurrent acute as well to progression to chronic pancreatitis. And then Claudin-2, that's on the X chromosome, accelerates the transformation from acute to chronic pancreatitis in alcoholic-related disease. Now, if we talk about the A and Tiger Row classification with autoimmune pancreatitis, there's different types. Type 1, that is IgG4-related disease. Often we see this in middle-aged men. It's associated with potentially sclerosing cholangitis, as well as disease in other parts of the body with the IgG4. And we can find an elevated IgG4. You can see storiform fibrosis as well as obliterative phlebitis. In type 2, usually we see this in younger people, can be associated with IBD. And at the level of the biopsy, you will see granulocytic epithelial lesion or gels. And that type is known for a dramatic response to steroid. And then type 3 is now what we call for a checkpoint inhibitor, is another form of autoimmune pancreatitis. But as you've seen before, there's other manifestation of chronic systemic autoimmune conditions that can also present with autoimmune pancreatitis. So here are the HiSort criteria to help with identifying AIP. So there's the histology, the pancreatic imaging that you can see here with diffusely enlarged pancreas, a featureless border, sausage shape. You can have delayed enhancement with or without rim. You can also have the serology with the IgG4 being elevated sometimes. You can see other organ involvement, including biliary stricture, parotid or lacrimal gland involvement, retroperitoneal fibrosis. Response to steroid is also one of those criteria to help with the diagnosis of type 1 AIP. So now if we talk a bit about recurrent acute pancreatitis, which is another of the Tiger Row classification. So the recurrent acute is a distinct pathway to CP with the sentinel acute pancreatitis event model. It's going to be seen from repeated inflammatory insults that will lead to progressive fibrosing remodeling. And so a lot of those cases are due to an underlying other condition, such as genetic, metabolic, medication, anatomical defects. So really important to try to mitigate any risk factors we can see in our patient population to help them prevent this progressing from a recurrent acute to a chronic pancreatitis. Obstructive etiology, so we see this if there's pancreatic duct obstruction from different things, tumors, stones, strictures, pancreas divisum, or annular pancreas. Sphincter OD dysfunction is a little bit more of a controversial etiology, but those are different things where there's an obstruction of the duct that may lead to chronic pancreatitis. And then I wanted to touch very briefly on a groove pancreatitis, where we see this in men being involved more, usually presenting between 40 or 50 years old, where there's tobacco and alcohol intake. And patients present with severe upper abdominal pain, jaundice, duodenal stenosis. And they really present because there's a mass or cystic change in the duodenal wall that causes this process. So it's a form of obstruction then. So if we could segue quickly to medical management. So really the goal of the medical management is fourfold. So first, we want a prevention of disease progression. We want to support nutrition as we can. We do want to do symptom relief and then correct exocrine and endocrine insufficiency. So first of all, at the level of the treatment approach, you want to see what risk factors can you mitigate or reverse to help with those patients. So for example, if there's a toxic component, cessation of this toxic component through alcohol and smoking cessation or lowering the triglycerides if they have hypertriglyceridemia. There's surveillance that can be involved too if they have idiopathic or genetic. If you find AIP, immunosuppressive therapy with steroids or others can be needed. If there's an obstruction, removing the obstruction. But really, we don't have any antifibrotic drugs yet available to help us with this progression. So really, smoking and alcohol cessation is very helpful. It can decrease pain in chronic pancreatitis. So it's also associated with decreased frequency of pancreatitis. And we know that alcohol and smoking have a multiplicative effect. So they may need behavioral therapy to help them stop, but sometimes pharmacological support is available too, and something we can think of keep in our arsenal of treatment to help our patients. So nutrition now. So if we think of small meals, sometimes that can help a little bit if there is some degree of gastroparesis. A very low-fat diet is generally avoided because there's a risk of micronutrient deficiency. So, there's and the evidence of supporting a low-fat diet, and it's not really strong. So I think you can tailor things according to what your patients are experiencing, how they're feeling, but very low-fat diet should be avoided. Vitamin D supplementation, especially if they have vitamin deficiency, is important. And then medium chain triglycerides, not usually recommended, but sometimes it can help with absorption since they're absorbed directly through the small bowel without the need of the pancreatic lipase. For pain management, I think a multimodal treatment approach is probably helpful, where you're going to consider, all the different tools you have. So opioids is one, potentially miscellaneous treatment, including neuromodulation techniques, considering surgical therapy and endotherapy. And I'll let Dr. Arshintala talk a bit about this in a minute. But what do we know about medical management? So antioxidants maybe could be helpful in decreasing pain. There's been multiple randomized trials that have had variable response or results. There's been different preparations studied. The population has also been very heterogeneous. But because this is safe and non-toxic, something I try in some patients to try to help, and this is what I provide them with. Non-coded pancreatic enzyme may also decrease pain. There's been 4 studies looking at enterocoded pancreatic enzyme, one with non-enterocoded enzyme, and only the one with the non-enterocoded enzyme showed reduction in pain. It's not really a significant difference in the mean daily pain score, though, or the average weekly analgesia consumption. So, and it's just one small study. So again, based on this, it's not something that's necessarily recommended all the time, but it may be potentially helpful. Pregabalin, though that is effective in the treatment of pain, is a randomized controlled trial, intention to treat. The outcome was measured at 3 weeks, and they assessed the change in opioid use and pain score. And they found that the people on the pregabalin had a bit more adverse event like CNS side effect of feeling drunk, but this is something that usually wears off. So it's worth kind of counseling patients to try that because this is something that is effective and in our arsenal. It's not an opioid. If you combine it, pregabalin and antioxidant, that can also sometimes be helpful as a double-blind randomized controlled trial that included 87 patients with calcific chronic pancreatitis after the duct had been cleared. And they compared pregabalin antioxidant versus placebo. And then what they found is that there was a significant pain reduction, reduction in the Isbecki score, and when in the group that had the pregabalin and antioxidants. And that persisted for 6 months. Another double-blind randomized controlled trial of 90 patients showed, again, a decrease in the pain score and then decrease in the non-opioid analgesia requirements, as well as a number of admissions. So something to keep in your arsenal, considering those two together. So other adjunctive treatments for pain. So we've talked about pregabalin that's effective for neuropathic component. The amitriptyline or triptyline can be used at lower dose for visceral pain. Usually you need to get to a level of 50 to be helpful. SSRI, SNRI sometimes useful, but is limited data. And then can consider plexus block that I'll let Dr. Ashri Natala talk a bit about in a minute. That could potentially help for short term in some cases. Now, if we look at tramadol versus morphine, we see that comparing the two in a double-blind randomized control trial, the pain and intensity, patient-rated analgesia, and the interference with the gut motor function showed that the transit time was significantly improved in the tramadol group compared to the morphine group. And then tramadol achieved analgesia with less effect on the gut than the morphine. So that's also something to consider before stepping up to opioids. And then here we can see a beautiful paper by Dr. Phillips that came out this year looking at the prevalence and pattern of opioid use in chronic pancreatitis. And you can see that she showed with her team that there was a high prevalence of opioid use in the patients with chronic pancreatitis. 44% overall used it, and that neuromodulator were used in 40%, and that there was an independent predictor of increased strength and frequency of the opioid with the increase in the severity and the history of plexus block. And that we can see that their pain was associated with significant impairment in their quality of life in all the domains. So I think opioid is a tool that's used, and this is helpful to give us information on how many patients with chronic pancreatitis are on those medications, so that more studies can be done to help us understand what's the best way of treating them. So if we talk about enteral nutrition, that's also something that can be considered. This is an old study from 2005 where they used long-term enteral nutrition to improve body weight and pain. It was a retrospective study of 57 patients that had moderate to severe pain, and then 53 of them had PEG-J and 4 had direct percutaneous jejunostomy. And they were treated with enteral feeding for 113 days. The body weight increased significantly, and then their pain decreased from 96 to 23%. And then just one had a complication with a colonic injury from the direct percutaneous jejunostomy placement, but otherwise patients tolerated it very well. So this is something that is in our arsenal, can be considered and can be really helpful through that or through nasojejunal feeding tube potentially too, that can be tolerated for a few weeks. CBT now, there's a randomized trial looking at CBT through internet versus control, and they included 30 patients with suspected or definite chronic pancreatitis, and 80% found the program acceptable, and 64% completed the sessions, and they felt that there was a moderate to large effect of reducing pain intensity and interference with their life. And then there was more treatment responder in the internet than in the control group. So this is something encouraging that could be a tool to help our patient population. So now if we, maybe I'm going to show you because I think I'm running out of time. Exocrine insufficiency is also something that we need to treat. And I think I'm going to be sharing those slides. So maybe I can skip through this. Right, Dr. Phyllis, am I running out of time now?
I think you have a few more minutes, and so feel free to take your time. Maybe we'll end in about 5 minutes just to make sure we have room for questions at the end.
Absolutely. So yeah, so maybe I can show you here. So exocrine insufficiency is treated with pancreatic enzyme replacement therapy, and the indication is steatorrhea, weight loss, or fat-soluble vitamin deficiency. Usually we start with a dosing of 40 to 50 units of lipase per meal, and you can titrate according to symptoms. The enteric-coated formulation is preferred. If you use a non-enteric-coated, you will need to use an acid reducer medication to keep the medication from inactivating. And maybe it could help decreasing ductal pressure potentially and help with pain in selected cases potentially. This is the different formulation, and I found this beautiful picture to show you the size of the pills of the different formulation. You can see that they're all porcine products. And there's one that is non-enteric-coated, the others are enteric-coated, and there's one that has bicarbonate granules added to the formulation. We have to remember that pancreatic enzyme replacement therapy is temperature sensitive. The enzymes degrade over time and it has a limited time of effect. So you want the people to take it at the time of eating, at the same time as food intake is preferred. Different side effects are included here. I think that obviously the most concerning one is fibrosing colonopathy, which is a concern when the doses are very high, more than 6,000 units per kilogram per day. So the dose we recommend are not at that level. Also have to think of endocrine insufficiency or type 3C diabetes that is caused by the loss of the islet cells. And this is a management challenge because you lose the insulin, but also the glucagon. So they're at risk of getting hypoglycemic. At the early stage, sometimes metformin can be useful, but insulin or insulin pump for titration of their sugars often needed. And of course, we treat those with the assistance of our endocrinologists colleagues. Metabolic bone disease, I think the screening and the diagnosis is something important too, because we know our patients with chronic pancreatitis are at high risk of getting osteoporosis. So bone density is recommended and is the gold standard. And you see how those are defined for osteoporosis and osteopenia. A recommendation of the screening is based on professional are experts, but it's not a guideline recommendation. But you could consider one at baseline, and then definitely consider in a high risk groups such as postmenopausal women, men over the age of 50, people with a history of low trauma fracture, or people with exocrine insufficiency. And then after that, you could consider doing it every other year for those with osteopenia. I just want to put a little plug that we've been working on looking at opportunistic screening with the CT scan, looking at the Hounsfield unit at the level of the L1 vertebrae to help us predict patients with osteoporosis. So key points, we've talked about the Tigero classification. We've talked about the importance of alcohol and smoking that are still very predominant as causes or cofactor worldwide. So something that can be worked on. Genetic autoimmune forms are more and more being recognized. And, you've seen that there's many ways we can treat our patients medically. And this is really something that should be done multidisciplinarily. And then you want to work on the proper use of pancreatic enzyme, analgesia, and then nutritional support, tailor your pain strategy according to etiology, and then proactively monitor your patients for complications. Thank you for your attention.
Thank you so much for that excellent talk. It was a wonderful overview and it really touched on so many of the key points in chronic pancreatitis. What a challenging disease. Yeah, without any cure or treatment at the current time, we are really reliant on these things to make patients' lives better. And so thank you so much for that excellent talk. A reminder to to the participants, please put any questions you might have into the chat. In the interest of time today, we'll move to Dr. Akshantala's presentation, and then we'll come back actually for a discussion at the end of it in order to bring home key points and raise any additional questions that you might have. But thank you again to Dr. McNabb-Baltar, and welcome, Dr. Akshantala. It's so nice to see you. Thank you for being here today. We are just thrilled to have you.
Thank you, Dr. Phillips, for the kind invitation.
I just wanted to give a quick introduction to our audience members so that they're aware of your background. But Dr. Akshantala is an assistant professor of medicine at Johns Hopkins University School of Medicine, and his research is focused on both the medical and endoscopic evaluation and treatment of inflammatory disorders of the pancreas. Currently, he is director of therapeutic endoscopy, medical pancreatology fellowships, and the lead center for endoscopic innovations. And so, again, we are just thrilled to have you here today in order to talk about role and scope of endotherapy for chronic pancreatitis. And without further ado, I will cede the floor to you. Thank you.
Thank you. And thank you again from CAPER and for Pancreas Academy for this invitation. And I'm very happy to see what the Pancreas Academy is continuing to do in improving the education and knowledge for clinicians and ancillary staff on pancreatic disease. So we're continuing today's theme and switching gears. So we will talk a little bit more on endotherapy for chronic pancreatitis. So we heard previously on the medical management for chronic pancreatitis and all the nuances that are involved. So these are my disclosures. So we will talk very briefly on pathophysiology of chronic pancreatitis, specifically thinking about ductal obstruction and management of ductal obstruction, which is the most relevant aspect when it comes to endotherapy. We will talk about pancreatic duct lithotripsy and also pancreatic stricture management. And when we think about chronic pancreatitis management, the endotherapy of it is focused more on symptomatic chronic pancreatitis, more about the painful chronic pancreatitis, which is around 80% of chronic pancreatitis. Among that, the different treatment options focus on the celiac plexus block from using EUS, the pancreatic duct stone treatment using ERCP or ESWL, and the pancreatic stricture treatment using ERCP. This is how we will be dividing today's presentation. And I will also touch upon the painless chronic pancreatitis management as well. I will not be talking about celiac plexus block, especially because the most recent guidelines have also highlighted about the limited benefit and role for celiac plexus block in benign conditions like chronic pancreatitis. So that is the reason I will not be talking about it. And very briefly, thinking about what are the different mechanisms involved that might be contributing to pain or symptoms in chronic pancreatitis. Is the pancreatic duct obstruction more the plumbing issue, and the pancreatic neuronal inflammation or the neuropathy or the wiring issue? So these are the two aspects that causes symptoms in chronic pancreatitis. So thinking about the pancreatic duct stone, which is relevant for endotherapy, if we look into what are these stones made of, the pancreatic duct stones are made of calcite, calcium carbonate. These are very, very hard, unlike the stones in the bile duct or gallbladder, and unlike the urology stones, which are oxalate, we have much more harder stones called calcite. And these are arranged in layers after layers. So it's very tricky to break them up or remove it. So a variety of modalities are considered. On one side is the ESWL, extracorporeal shockwave lithotripsy, which I will go more in detail. And then there is the endoscopy-based approach, like the pancreatoscopy. So we can enter the pancreatic duct using the pancreatoscope, and we have a variety of accessories available. Now, one is the laser lithotripsy using laser, as you can see in the video onto the right side, or electrohydraulic lithotripsy that you can also use to break up the stone. So focusing a little bit more on pancreatoscopy-based treatment for pancreatic duct stones, in this review, we can see the different options that have been used using pancreatoscopy to break up the stones. Looking at the technical success is fairly high. The clinical success also is reasonable. But if you look at the adverse events with these invasive options using either EHL or laser, it is around 10% risk of post-procedure complications. And there are many other studies that went more into detail looking at the success of doing these procedures. And in this study, you can see the risk of post-procedure pancreatitis is 28%. Majority are mild, but some of these patients can have pretty significant pancreatitis, especially because these accessories like laser and EHL can cause ductal injury, ductal leak, and can cause significant severe pancreatitis episodes. And as you can see in the pancreatoscopy, there is decent proportion of patients who had failed cannulation, because especially when the stone is at the papilla, right at the opening of the pancreas duct, it is very hard for us to advance the instruments. So there is often high risk of failed cannulation. And these are all some meta-analysis that looked at pancreatoscopy for treating the pancreatic duct stones. They have reasonable technical and clinical success rates, but again, many of them use inconsistent definitions, so hard to interpret some of the literature. Now, the other modality of intervention is ESWL, extracorporeal shock wave lithotripsy. So many of the European countries in Germany and Belgium, this is where some of the studies began on using ESWL for pancreatic duct stones. But several Asian countries, especially India and China, took this on a large scale. And there are series of patients with 10,000, 15,000 plus patients, very large experience, who have really refined the techniques of how to use ESWL for pancreatic duct stones. And these studies have shown like very high technical success rate, as high as 100%, 75 to 100%. In our own experience, the technical success is over 90% when we use the right protocol. And majority of the patients require less than 3 sessions. And the good thing about ESWL compared to pancreatoscopy is it is non-invasive. So less risk of post-procedure complications, less risk of causing trauma to the pancreas duct. And there have been like some studies that have looked at ESWL versus endotherapy or pancreatoscopy. So what it was identified was that the technical success was pretty similar. In this smaller study, the adverse events are similar, but in the larger studies, the adverse events are much higher for pancreatoscopy. And whenever the stone is very big, it is less successful to treat with pancreatoscopy. But it is not so much about ESWL versus pancreatoscopy. One should consider what the combination would be like, ESWL versus ERCP plus ESWL. And what it was identified was that spontaneous stone clearance after ESWL alone was obtained in 70% of the patients. So many patients might not even require ERCP after ESWL. But if there is a stricture and the ERCP was not performed and the stricture was not treated, the stone recurs. So it has to be like a right combination of personalized approach. Some patients might need just ESWL. Some patients might need ERCP plus ESWL before or after ESWL. So there are many unanswered questions about which patient need what type of intervention and what type of intervention should be performed first. And these are some of the guidelines that have highlighted what should be done for pancreatic duct stones. And majority of these guidelines and expert opinions recommend just doing ERCP when the stones are small, such as less than 5 millimeter stones. But if they are bigger, more than 5 millimeter, ESWL is preferred to break up the stone. And after the stones are broken, if there is no stricture, one might not need ERCP, but if there is stricture, usually one might need ERCP so that the stone does not reoccur. And these are some of our patient examples. This is a CT scan of a patient with chronic pancreatitis. And as you can see on the left side, this patient had fairly large size stones and pretty dilated pancreas duct. And after the ESWL, the stones are completely gone. You do not see the stones anymore. So as you can see, completely resolved stones. So, and this patient did not require ERCP after ESWL, and he did very well. And when we think about the ERCP and followed by ESWL or ESWL followed by ERCP, we do a lot of planning for these procedures. And as you can see here, this is the CT scan of one of the patients who had, this is the CT scan before the ESWL and ERCP procedure. And then he had the ESWL procedure. And I'm trying to move my screen forward. I'm sorry, this might have frozen. I might need to restart this. I'm sorry, I had some heavy size videos in it, so it might have crashed.
No problem. In the interim, actually, if it's back up, we'll just keep going.
Sure. So I can go directly to this. So I was showing this images of CT scan of a patient who had the the CT scan done before. On the left side, this is the ESWL radiograph. On ESWL, we use X-ray to find the stone, and this is the stone at the beginning of the procedure. And after 2 ESWL sessions, you can see on the left bottom, the stone has gone. The stone has disappeared, maybe small fragments left. On the right side, you can see the ERCP for this patient. So the catheter is going in, we are injecting contrast, and you see this dark space. That is the empty cavity left over after the stones are broken up. So now I'm advancing the balloon to stretch the stricture. Usually the stone and stricture occur together. So I need to stretch the stricture so that I can clean up the stone fragments and also to help the pancreas juice flow and to reduce the risk of the stone forming again. So that balloon has been used to dilate the stricture. And after that, we place a stent into the pancreas duct. So this is an example of a patient with pancreatic duct stone who had ESWL first, followed by ERCP. Historically, our ERCPs used to take like much longer. The procedure difficulty was also very high, trying to get into the pancreas duct. But since the use of ESWL, the procedures have become so much easier, less traumatic to the patients, and good for the patient care and also from our procedure perspective. And highlighting a little bit more about the logistical aspects of ESWL. In United States, historically, it was the urologist who was doing the ESWL. And because urologists do the kidney stones ESWL, we used to send our patients to urologists to do the treatment for pancreatic duct stones. But urologists are not so much used to the anatomy. Urologists are not used to the calcite stones. They are more used to the oxalate or urate stones. Our stones are much harder. So this study had shown that when a urologist does the ESWL, it is less effective compared to a gastroenterologist. So at our practice in the last 3 years, it has been a gastroenterologist driving the ESWL, and we have noticed definitely an increased technical success with the ESWL. And this is a review we have published that gives some guidance to gastroenterologists on how to do the ESWL procedure themselves. What are all the settings that need to be used, the power, frequency, and so on. And this is the protocol that we use. In our protocol, we also use secretin hormone during the ESWL procedure. When we use secretin, the fluid builds around the pancreas duct stone and the shock waves are transmitted much better to the stone and it's broken up much better. And as the stone fragments, as the stone turns into pieces, the secretin helps in flushing the duct so that the fragments all move out and there is less risk of something called strain-straws phenomenon, or the tram track like stone, which gets often stuck and clumped together. So if you use secretin, there is less risk of strain-straws phenomenon as well. And from a logistical perspective, it is important to know how many sessions of ESWL do we need so we can plan the procedure accordingly, because we don't have our own in-house ESWL. We have to bring the equipment to the endoscopy suite. So we have developed this formula that helps predict how many sessions of shock waves does it take to break up the pancreatic duct stone. And we also have an app for this. And we just put in the stone size and the stone density in Hounsfield unit on CAT scan. And this formula will tell us how many sessions of shock waves does it take. And this has helped us in planning the logistics. The next aspect on endotherapy in chronic pancreatitis is the pancreatic duct stricture. And as I mentioned, if we do not treat the stricture after removing the stone might recur. We have noticed it ourselves, and there is a lot of literature on this, that if there is a tight stricture, there is high risk of the stone coming back. And once we relieve the stricture, the pancreatic duct is going to decompress, less pressure in the pancreas duct. And this is what we hypothesize, that it reduces the pain as well. And what it was noticed was that once we place the pancreatic duct stents, we want the stents to stay there for around 6 to 12 months. 6 to 12 months, and at least 10 to 14 French of 1 or 2 stents is what we need next to each other to stretch the pancreas duct stricture. And in our practice, we bring the patients every 6 months and upsize the stents and leave the stents for at least 12 months so that there is less risk of stricture reoccurring. There have been some studies that looked at metal stents instead of plastic stents to treat the pancreatic duct stricture. And it was noticed that the metal stents cause higher risk of complications and compared to the plastic stents. So in our practice also, we do not typically use metal stents. We only stick to multiple plastic stents. And if we look at some of the studies that looked at ERCP, ESWL, and the efficacy in managing the pain from chronic pancreatitis and the short-term efficacy and the long-term efficacy, it has been inconsistent in majority of the studies. And the majority of the studies showed numbers like this, like 45%, 58% pain relief. And as we look at more long-term, that efficacy diminishes even further. So it is questionable about how effective these therapies are, or maybe it is effective in some patients and may not be effective in other patients because there are different mechanisms of pain pathways that which causes the pain. So one might need to recognize what might be the predominant pathway causing pain in each patient and decide on the appropriate type of intervention or medical management. So this is where we have to comprehensively phenotype the patient, whether the pain is more from the plumbing or the pancreatic duct obstruction, or is the pain coming more from neuropathy or the wiring issue. Right now, there is no well-validated phenotyping strategy, but there is a lot of work ongoing by our group and many other groups, including Dr. Phillips, who has been leading the work on pancreatic quantitative sensory testing and other ways of phenotyping the type of pain and understanding what type of neuropathy a patient has and trying to understand what type of neuromodulator to use or what type of treatment to use. And on the other side, when it comes to pancreatic duct obstruction and thinking about pancreatic duct pressure, so there is no good way to quantify the pressure in the pancreas duct. Historically, the initial studies from 1970s, the surgeons have connected some pressure sensor into the pancreas cyst that is communicating with the pancreas duct to measure the pressure in the pancreas duct, or use some kinds of transducers during ERCP to measure pressure in the pancreas duct, but they are not very consistent, they are not very reliable, and they're also very invasive. So we do not have a very good strategy to measure pressure in the pancreas duct. And also we know that ductal dilation does not mean ductal hypertension. It could be just ductal ectasia. So these are some initial remote studies that suggested that the pressure might be very high in the pancreas duct or in the fluid collection that might be causing pain. But there are other studies that also showed that the pressure and the pain does not correlate very well because of the limitations with the technology that was being used. So our group has developed an MRI-based technology to measure pressure in the pancreas duct. This is an ongoing work. The current publication is under review, where we have done initial development work to develop a new technology based on MRI to measure pressure in the pancreas duct. And we have done some ex vivo validation and also a prospective clinical study to validate the technology. And this is continuing on ongoing work among multiple centers participating. And briefly, I want to also talk about, should we do endotherapy like ESWL and ERCP in painless chronic pancreatitis if the patient does not have any pain, which is the case in like 1/5 of the patients? And the answer is maybe selectively. There has been some literature that showed that if we relieve the ductal obstruction, there is less risk of the pancreas atrophy worsening. So we can preserve the pancreas function, the exocrine function, the endocrine function, and maybe there will be some regrowth or regeneration of the pancreas or regain of the function. There is some literature suggesting all of these. And there are some other studies that showed that it might not be the case, especially in a more end-stage disease. So we might need to be selective in who we want to do interventions if it is painless chronic pancreatitis. For example, on the left side, we have a patient with a stone and a dilated duct and reasonably preserved pancreas parenchyma. And on the right side, we have another patient with a large duct and a large stone, and pancreas is completely atrophied, and the patient is already diabetic. So I would consider doing intervention for the patient on the left side, who is not diabetic, who has a large stone, and has a preserved pancreas parenchyma. So again, these are things that are yet to be answered, but to be considered in a selective group of patients. And briefly about surgical interventions, if the endotherapy fails, so we might consider need to do a pancreas duct pressure relieving interventions, such as Fry procedure, Brewster's procedures, and others. And there have been studies that looked at should we do surgery early or much later after repeat failed endoscopy approaches. And some of this literature has suggested that one should consider surgery early if it does not look like the endoscopy is working. In putting this all together, in our practice, we consider doing ERCP for a main pancreatic duct stone that is small, less than 5 millimeter. And if the stone is large, such as more than 5 millimeter, we consider ESWL and ERCP if the stones are clear are not cleared or if there is a stricture that is present. And if there is a pancreatic duct stricture, we'd like to leave the stent for at least 1 year and repeat exchanges as needed. In conclusion, is endotherapy effective? Yes, in some patients. So we have to be selective in our approach. And celiac plexus block has limited efficacy in chronic pancreatitis. So ERCP is effective for small stones and ESWL for larger stones. So stent therapy for 6 to 12 months is effective for structure remodeling. And endotherapy may be effective or required in painless chronic pancreatitis in a selective group of patients. Endotherapy results are widely variable, and phenotyping is essential for patient selection. And evolving techniques like pancreatic quantitative sensory testing and non-invasive pancreatic duct pressure measurement may assist in precision or personalized medicine. Thank you.
Thank you, Dr. Akshantala, as well for what an excellent talk. A complicated topic for sure, and well dealt with. So thank you so much. To the attendees, if you do have questions, please feel free to place in the chat, and I'll invite Dr. McNabb-Baltar back to our panel as well, because I think we have one question at least that was initially directed for Dr. McNabb-Baltar. Given both you practice pancreatology, happy to have you both weigh in on how you might counsel patients. But the question from Miriam is, should PERT be continued for life or stopped at some point? How can the effectiveness be monitored, if at all? And added from me, how might you counsel patients about this when you start them?
Yeah, so usually when you start it, I recommend to continue it long term. What I tell the patients is that you should take it with your meal. So usually I say take the first pill halfway after a few bites and then the other pill halfway through your meal. That's usually what I say. I think this is not like based on strong evidence that you need to take it separately like that, but this is what I've done. And then counseling is, you monitor for symptoms. So let's say the person has steatorrheic symptoms. If they improve, great. If they don't improve, but they have liposoluble vitamin deficiencies that do improve, that will be, then you can just continue. If you have steatorrhea that does not improve, you could increase the dose. You can add PPI. There's like different things you can do to help with those things. But it's usually a lifelong thing. Yeah. How about you, Venkata?
I agree, Juliet. So it might be like more of a long-term commitment and more from an endotherapy perspective. So in some patients, once I relieve the stone and stricture, everything is open. I do clearly notice the patient saying that the pain has improved, they're gaining weight, their steatorrhea has resolved. And in a small subset of patients, then I start checking their fecal elastase to see if it's a good way of monitoring. And I noticed that it takes some time for the fecal elastase to start coming up. In some patients, the elastase does not come up as much up, but their steatorrhea is completely gone. And then it is a question for me, should I ask them to continue PERT or not continue PERT? Dr. Suresh Chari has written a nice review about how EPI is not black and white. There are different grades of EPI. So this patient may still have like some extent of EPI still there that may still cause some micronutrient deficiencies. So it's a tough question. We do not know the answer yet, but there may be some patients I might be able to say, okay, to stop using PERT, especially given the cost and other aspects involved. But again, we still have to study this better.
Thank you both. Yes, this is a challenging a challenging arena because I think we face a lack of accurate testing resources. Fecal elastase is a wonderfully and readily available test, but it requires a high pretest probability and the correct clinical situation in which to order it. And so, unfortunately, we see a lot of false positive results, and I'm sure both of you can probably relate to that. Just that it can be diluted in many clinical settings, and so unfortunately, it's not. It's a test with some caveats. And so I'll direct this question to both of you as well. From Shelley, is there a timeline of when you would expect steatorrhea to resolve after you start pancreatic enzyme replacements?
So it's so interesting. So in theory, you should start to see improvement within like a week, but in practice, it takes a long time. The patients can continue to experience steatorrhea even if you're giving them high dose. So it's not as, again, black and white as it's described, it's very gray. So it can take time, and people need to be advised properly to take it with the food as well as with the snacks. Um, but yeah, ideally, you see some improvement within a week, yeah, I would say, but it's gray. It can take longer.
Excellent. To Dr. Actiontala, I have another question actually for our panelists. No one has asked this, but of course, the field of pancreatic endotherapy is one that is quite complex and is also constantly evolving. You yourself are at the forefront of this in innovation and so forth. And I wondered how you might recommend to trainees or coordinators who are new to the field ways in which they can educate themselves about what is going on for patients or what's being recommended or what they've undergone, if there are sources that you yourself have used or ways that you've done this throughout your training.
Absolutely. So it is, like you pointed out, Anna, the pancreatic endotherapy is much more complex. If you look at the ASGE grading, it's considered level 3 ERCPs. From a technical perspective, so one needs like more advanced training for one to be able to do pancreatic interventions, because in ERCPs, the golden rule of thumb is stay away from pancreas in general. But here we are asking them to go into the pancreas and do interventions. So one has to be really cognizant of what they are doing, because pancreas is so sensitive, and causing trauma to the pancreas duct can cause pretty significant complications. So utilizing the resources from ASGE and European Society, ESGE, they have excellent reviews, excellent technology reviews, and other videos and other resources that talk about what are the nuances of the technical aspects one has to consider when doing an intervention in the pancreas. And for those who want to be just make themselves aware, those who don't do these procedures, but want to know what are being done, what are these technical successes and so on, they can also look at these reviews from ASGE and ESGE.
Fantastic. Thank you. That's wonderful to know. And also, for myself as a medical pancreatologist to be able to keep up with what the recommendations are and the latest techniques, certainly that's very important and much appreciated. Our time is running short here at the top of the hour. And so I wanted to make sure to take a moment and thank you both again so much for your presentations and these excellent topic overviews. Thank you, Dr. Actiontala and Dr. McNabb-Baltar. A reminder to our attendees and to those of you who might be watching this later, these will be posted in webinar fashion from the CAPER organization, and so please feel free to view and review at your leisure. This has really been wonderful. If no further questions today, I think we can end there. But again, thank you to both of our excellent expert panelists, and we'll look forward to seeing our attendees for 2 more sessions this year on September 25th and October 1st.
Thank you.
Thank you.